Okay, so now we're going to cover some other topics associated with bone pathology that are directly related to what you will see in clinical practice. Now we're going to cover some markers of bone formation that we can detect in blood or serum samples, and some of these maybe even in urine samples. So these are useful markers in that we can take a patient blood sample, look at what's in the patient blood, and then gain some insight as to what might be happening in the bone based on what markers are present in blood. So the first one is alkaline phosphatase. So this is just an enzyme that is secreted or made by the osteoblast cells. So osteoblasts secrete collagen. As part of that process, the collagen becomes mineralized, and alkaline phosphatase is part of that process. So if you have high levels of alkaline phosphatase in your blood, that could indicate that there's increased bone turnover going on somewhere in the skeleton, and this could be indicating a fracture. It could be predicting metastatic bone disease due to cancer growing in bone at some sites that might not be entirely obvious. So we'll see raised levels of alkaline phosphatase in patients who have some sort of bone disease going on potentially. We also see P1NP. This is pro-collagen type 1 propeptide. So collagen is a protein that's secreted by the osteoblasts. That collagen becomes mineralized. Now, as the collagen is secreted from the osteoblasts, the N-terminus, which is basically the first bit of the protein, gets cleaved off, and that just floats away from the cells. So if you can detect P1NP in patient blood, that can only come from active osteoblasts creating newly synthesized collagen. So the presence of these two markers together would confirm that there is some sort of bone remodeling, bone synthesis going on, and this can be measured compared to the normal reference range for normal people. So related to that, we have markers of osteoclast activity. So if you remember, osteoclasts are the cells that eat away at bone, and their job is to secrete acid and enzymes that degrade the collagen and the matrix. So their main target is type 1 collagen, which is what the osteoblasts have made, and they secrete acid and secrete enzymes that then chop up this collagen. Now, collagen is a protein of a triple helix of 3 peptides twisted together almost like rope, and then that is cross-linked by chemical bonds. So what we can see when collagen is resorbed is collagen that is cross-linked, twisted together into 3 strands with what we call a cross-link at either the C-terminus or the N-terminus. The N-terminus is the start of the protein, the C-terminus is the end of the protein. And if we can detect cross-linked collagen, then we know that this is collagen that has been liberated from the bone. That can only occur when an osteoclast has eaten away a bit of bone. So if we detect NTX and CTX in patient blood, that means that there is, especially if we detect enhanced levels of that above a normal reference range, that means that there is enhanced osteoclast activity going on in that patient. Similarly, we can just detect tartrate resistant acid phosphatase, TRAP, which is an enzyme secreted by osteoclasts. And again, if we detect high levels in patient blood, that suggests there's a lot of osteoclast activity going on. So these markers are used not so much in routine bone disease, but if you've got a patient who comes in suspected of got maybe tumour growing in bone, before you do a bone scan, you might want to look at bone turnover markers, and if those levels are raised above a normal reference range, then that would confirm that there's high risk of a metastatic cancerous lesion growing in the bone. So what we can now move on to is how we can modulate bone cell activity using drugs. And there are a particular class of drugs which are used to prevent bone resorption, so basically killing off the osteoclast cells. And these drugs are called bisphosphonates. And these bisphosphonate drugs resemble pyrophosphate, which is part of the mineral that binds up with calcium to create calcium phosphate and a related mineral. So pyrophosphate will accumulate in bone, so will bisphosphonate. So if we inject a patient or get a patient to ingest a bisphosphonate type drug, all of this bisphosphonate will stick to the surface of bones. Now this drug will then be laying there on the surface of a bone until an osteoclast comes along, degrades that bit of bone and takes up this drug into the osteoclast. So the chemical structure is an oxygen, phosphorus, oxygens, OH groups. In the bisphosphonate you've got carbon, you've got these two R groups, and these are just chemical groups. Different bisphosphonates have different R groups. It can be a long chain of carbons, it can be a phenol type group, and it's got the same phosphate type bit here. So when an osteoclast ingests this, on these R groups are chemical groups which are toxic to osteoclasts. So basically, if you take bisphosphonates, the only cells in your body that will get appreciable levels of bisphosphonate are the osteoclasts, and they will be killed off by ingesting the bisphosphonate. Now these drugs are given fairly routinely now to patients with osteoporosis, but also to Pagets disease patients. And Pagets disease, we've just seen that you have enhanced osteoclast activity and on enhanced osteoblast activity. What we're doing here with bisphosphonates is uncoupling that. So if we kill off the osteoclasts, that will also reduce the bone degradation that's going on and give that newly produced collagen time to mineralize and harden to create much harder bone. If we leave the osteoclasts to just work at this higher rate that they are doing in Pagets disease, then we tend to get a chaotic bone formation coupled with rapid bone degradation, and the collagen present in bone never really gets a chance to mineralize. So what this graph is showing here is the effect of treating with bisphosphonates for a period of time on bone mineral density. So this graph here shows the percent change in bone mineral density at the spine and the hip. This is a time period in years, and we've got alendronate, which is a bisphosphonate, and the placebo, which is obviously no treatment. And what we can see is an increase, quite considerable increase in spine bone mineral density in patients that are on alendronate versus a placebo, where bone mineral density does go up very, very slightly. And the most likely reason for this is if we're dealing with patients such as osteoporotic patients, they get diagnosed with osteoporosis and then they start to change their lifestyle to some extent, become more mobile and so on, and make some active changes to the lifestyle. So it's not unusual to see a rebound of bone mineral density in the placebo arm, but it's nothing compared to the bisphosphonate treated. So this is showing that in the bisphosphonate treated patients, the osteoclasts are being killed off, they're unable to degrade bone. The osteoblasts are still making bone, it's just that in osteoporosis, due to low levels of estrogens, the osteoblasts are working at a slower rate than normal. So all we're doing here with the bisphosphonate is restoring the balance so that the osteoclasts are working at the same rate as the osteoblasts. However, they're both working at a slower rate than normal. And we can perform this type of treatment not just for osteoporosis, but also for Pagets disease. And this is just showing Pagets disease, looking at serum alkaline phosphatase levels. We're killing off osteoclasts, but we're also affecting alkaline phosphatase, which is a marker of osteoblasts. So by treating with bisphosphonate, we're reducing the osteoblasts that are present in bone, and that's because we are uncoupling this chaotic rapid bone degradation coupled with rapid bone formation that's present in Pagets disease of bone. Okay, so to summarise, what we've covered so far is that osteoblasts are the cells in the bone that make new bone. They secrete collagen. That collagen becomes mineralised thanks to alkaline phosphatase, and we get calcium phosphate mineral deposits within the layers of collagen that are being secreted by the osteoblasts. Osteoclasts come along, eat away at that collagen, release fragments of collagen into blood that we can detect, things like NTX and CTX, collagen fragments as markers of bone resorption. So if we see enhanced NTX and CTX, we know the osteoclasts are overactive, shall we say. We've looked at where the osteoblasts and osteoclasts come from. Osteoblasts are bone marrow stromal cells, osteoclasts hematopoietic cells. Now this is important because some of the diseases you might come across could be caused by defects in the bone marrow or hematopoietic cells. So you may well come across children with osteopetrosis, which is really thick bones with very small bone marrow cavity. You may come across children with brittle bone disease, which is a disease where the collagen has got a mutation in it so that it doesn't lay down properly. Now, different diseases are caused by different cell types. So if you're dealing with a child who's got osteopetrosis, it could be due to osteoclasts that don't work properly. So those osteoclasts are not eating away at the bone, so you end up with big, thick bones called osteopetrosis. These patients could potentially be cured by having a bone marrow transplant. But just be aware, a bone marrow transplant only transfers the hematopoietic bone marrow cells, not the stromal or connective tissue bone marrow cells. So you could have two patients, both with osteopetrosis, one that's got a defect with the osteoclasts that could be cured or treated by a bone marrow transplant, and a separate patient that has got a defect with the osteoblasts, which are actually responsible for activating the osteoclasts. And if the defect is on the osteoblast, then a bone marrow transplant will not help to treat that patient. So these are interesting little quirks of bone biology that you may come across. Either way, you will certainly, by flicking through patient notes, notice bone markers like P1NP, NTX and CTX, particularly if you're dealing with a cancer clinic. Prostate cancer patients, multiple myeloma and breast cancer, those tumours metastasize to bone. So there's a good chance that those patients will have had bone markers looked at, so at least you'll then know what is the rationale for looking at bone markers in a prostate cancer patient. So this is just a few slides at the end of the lecture showing cancer-induced bone disease. These are osteolytic lesions. These are holes in the skull caused by multiple myeloma, which is a B-cell tumour. This is a lesion in bone caused by breast cancer eating away at, breast cancer enhancing osteoclast activity to degrade the bone in this region here. So that's cancer-induced bone disease, osteolytic. This is osteosclerotic, associated with prostate cancer. So prostate cancer grows in the bone marrow, metastasizes and causes excessive bone formation, what we call an osteosclerotic lesion. So these are just some extra slides if you're interested in cancer-induced bone disease. So after that brief digression, osteoporosis, a disease where we've got reduced estrogen levels resulting in reduced osteoblast activity, so net effect is bone loss because the osteoblasts are not working as well as they should. Pagets disease, we've got the increase in both osteoblasts and osteoclasts, creating a chaotic, weak bone. Both of these diseases can be treated with bisphosphonates, which accumulates in bone and poisons the osteoclasts, which resorb bone. And especially in Sheffield, which is where the bisphosphonate type drugs were initially discovered and developed, there's a history of using bisphosphonates both at the Western Park Hospital, doing a lot of clinical trials on these, but also in other clinics. You'll find a lot of clinical trials using bisphosphonates for both osteoporosis, Pagets disease and cancer-induced bone disease in local Sheffield hospitals, just because we've got a very strong background in bone biology research. And this is just showing the bone scan of a prostate cancer patient here with bone lesions in the ribs, in the vertebra, sometimes in the long bones, and showing how this differs to Pagets disease of bone, which is tends to have these big long lesions within the long bones. Now, Pagets disease and prostate cancer are sort of linked in a way in that a lot of Pagets disease patients are actually found by looking for prostate cancer in patients with a history of prostate cancer. We give them a bone scan. Occasionally we expect to find this, and what we actually find is this. Okay, so that's the end of this lecture. Those slides that I've just been showing should be at the end of your lecture after this summary slide.